Thank you to the Immunodeficiency Foundation for this great opportunity to speak to you today. I just wanted to say that this has been a fantastic organization to be involved with over the years, and I really appreciate everything that they do for our patients. So today, I know that you've got a whole meeting ahead of you, and you're going to be learning a lot about some very specific things about your diseases. But today I wanted to give you an overview of primary immune deficiencies. So what does our immune system do? So I think that's the first thing to think about. So our immune system is obviously very complex and has a lot of moving parts to it, but I like to try to simplify it and think about our immune system having two main jobs. And the first job that our immune system has is to get rid of what I call invaders. So invaders are things that shouldn't be there when we're healthy. So things like infection and cancer. So here is a little schema showing a T cell, which is one of our immune cells, one of our white blood cells, destroying a cancer cell. And T cells, like many of our white blood cells, have specific mechanisms to be able to recognize that this cell isn't normal. This is actually a cancer cell, and that should trigger the T cell to kill the cell. There's very similar mechanisms that we'll talk a little bit about for infections as well. But really, this is the primary job of our immune system. The other job of our immune system at the same time is that it needs to ignore everything else. So while our immune system needs to be able to distinguish and say, hey, this is a cancer cell, this is an infected cell, this is a virus, I need to get rid of it, the immune system also needs to be able to say, hey, wait, this is my own cell, this is a healthy cell, and I can't destroy this one. And so when this fails, when the immune system fails to recognize our own cells and our own healthy cells, this is when we are susceptible to autoimmunity and inflammation. So I'm going to talk about what I call the who, what, and where of the immune system. So who are the main players of the immune system? So the immune system is really a group of white blood cells and proteins that work together in a very highly coordinated response to protect us from infection, protect us from cancer. And I'm going to highlight during this talk how important that coordinated response is. Because when you have an immune deficiency, even if it's an immune deficiency that seemingly only affects one single part of the immune system, there's actually a cascading effect in that one problem with the immune system doesn't just affect that one cell, doesn't just affect that one part of the immune system, but it affects really the whole immune response because the immune system has to work together. So we can divide very broadly our immune system into two parts, and that is first responders and long-term protectors. So the first responders are our immune cells that are really always on guard, watching for invaders, watching for the first signs of infection, watching for initial transformation and cancers. And so I've just put names to a couple of the cells here that are some of the first responders. So neutrophils shown here might be familiar to some of you, as these are the main cells that have problems in patients who have chronic granulomatous disease. Complement proteins are proteins actually made in our liver that help our immune system to target infection. And deficiencies of complement can unfortunately lead to infectious susceptibility as well as autoimmunity. And then I've also put natural killer cells here. These are early immune cells that are really good at recognizing viruses and cancer cells. And finally, macrophages. Macrophages are great early responders. They gobble up a lot of things. They'll gobble up infected cells and they'll help to kind of clear things away. So after the first responders kind of recognize that there's a problem, they call in the long-term protectors. And the long-term protectors of our immune system are T cells and B cells. And so we're actually hearing quite a bit about these cells now with the COVID vaccine, and many people beyond the immune deficiency world are becoming familiar with T cell responses and B cell responses, in particular the antibodies which are made by B cells. And so T cells and B cells are really specialized members of our immune response that once they encounter a pathogen, meaning once they see an infection, they are really the cells that keep us protected for years and years from that same infection. or they're the cells that keep us protected long-term after we have a vaccination to protect us from infection. T cells are cells that can be directly cytotoxic, meaning directly able to kill viruses or cancer cells. And T cells also help our B cells, which are the cells that make our antibody responses. And so those antibodies circulate in our body and can be made in response to specific infections, and antibodies really help to clear infections. So now that we've had that very brief overview of who the players are, I wanted to just review kind of what do they do? What is the immune response look like? Here I'm referring to this as FAST, F-A-S-T, because the immune response is incredibly fast. It's actually going on in all of us all the time because we're always encountering challenges in our world, and it's quite incredible how quickly the immune system can respond. And so the first thing, the F, stands for find the problem. So in this little graphic here, this is showing a patient who is infected with a virus. The virus might be in the lung, it might be in the nasal passages, but really the first thing that the immune system has to do is say, hey, there's a virus here, there's an infection here. And that is a job of those early responders. And here this is showing a macrophage that's able to basically kind of almost gobble up that virus and to take it in and say, hey, what is this? And then after the first recognition by the immune response has to then ask for friends. It's pretty rare for immune cells to be able to clear an infection all by themselves. So there are certainly some very cells that are certainly essential for clearance, but they rarely do it all by themselves. And so here this is showing this macrophage after it ingests the virus and say, hey, this is a virus not supposed to be here. We need to do something about this. What it's going to do is it's going to call in its friends. In this case, I'm showing calling in some T cells and some B cells. So that macrophage is going to call in the T cells and say, hey, take a look at this. And cells actually like to talk by little receptors that they have on the outside of the cell. And they use these receptors on the outside of the cell to tell each other things like, hey, this is a part of a virus. I think you should really work to get rid of this. We need to get it some help. And then what that T cell can do is then recruit further help by recruiting some B cells to help make some antibodies for that virus. And then S, which is really the mission of the immune response, is seek and destroy. So this immune system, our immune response should actively seek out these infected, this virus, this infection, or the infected cells. And what you see here is that now that T cells have called in some B cells, these antibodies that the B cells are able to actually then go and actively find that virus and are able to target it for further destruction by the immune response. And then the last thing I have here is T, and that's to take some time to remember. This is a very coordinated response. This response by the macrophages, the early response happens within minutes. This response, getting the T cells in there, is hours to days. And then getting this antibody response can be days to weeks. So while efficient, this takes some time. So what we want with an ideal world with our immune system is that the next time we see this virus, we want this response to happen very quickly. We want these antibodies to be around. We want these T cells to remember this and say, hey, I know what that is. I've got to act fast this time. We want those B cells to be around to make that robust antibody response. This is also the basis of vaccination. So vaccination simulates this early response. Then when you actually encounter the real infection, you're able to very quickly mount this response because you have these memory T cells and B cells. So the last thing, talking about basics about the immune system, I want to discuss is the where. So where does this all happen? What are some important parts of our body for an effective immune response? Well, the immune response is everywhere. So we have immune cells in our skin, we have immune cells in our nasal passages, immune cells in our gut, but I wanted to highlight a few areas of our body that are particularly important in terms of places where immune cells are made and places where they kind of grow up and learn what to do. So the first is the bone marrow. And the bone marrow is that space in our long bones, and so shown here in a femur bone, also in our hip bones. And this is really where it all begins for our immune cells. So this is where there are progenitor cells shown here that can then grow into and develop into all the different types of immune cells that we need. And so this is why there are some patients with immune deficiency. If they have a problem producing a particular immune cell type within the bone marrow or a problem with the bone marrow, why they could potentially benefit from a bone marrow transplantation. The next area I wanted to highlight is the thymus. And the thymus is a little organ that actually sits on top of our heart. And I call this a T cell school. So while the bone marrow is where it begins, not all of the immune cells that leave the bone marrow are mature. Some of them go to different organs of our body to mature, but in particular, immature T cells have to go to the thymus where they receive their education. And it's in the thymus that T cells learn to recognize the difference between an invader and ourself. And so it's a really important place to learn that lesson so that when they come out of the thymus, they are prepared to fight infections, fight cancer, but not attack our own body. The next place I want to talk about is the lymph node. So lymph nodes, again, are all over our body, and you can see some of them highlighted in green in this picture here. And the lymph nodes are really where immune cells go to talk. In particular, T cells and B cells like to talk in lymph nodes. They like to share things like little pieces of viruses and say, hey, this is something that we have to respond to. It's also why when you get sick, you might have lymph nodes that become enlarged because there's a lot going on in there. The immune cells are talking to each other and trying to develop a plan. The next thing I wanted to highlight is complement. So I didn't talk about complement too much with the players of the immune system, but complement is a protein produced in a few different places, but primarily in our livers. And complement proteins are actually really good at sticking to bacteria. And they can help our immune system to recognize bacteria and to target that for destruction. And then the last thing I wanted to discuss is our GI tract, our gut. And I think about our gut as really the place where immune cells meet the world. So in the gut, they're exposed to all of the different foods and microbiota that we're taking in. And actually, our gut immune response is we're starting to recognize is more and more important into influencing our entire immune response and systemic immunity. So what are primary immune deficiencies? So they are a group of more than 470 now rare disorders that are caused by an inborn disruption of the immune system. And when I say inborn, primary immune deficiencies are not acquired. So you can't contract a primary immune deficiency from someone else. They're certainly not contagious. And it's not something that's caused by an infection. Primary immune deficiencies are generally genetically defined. So what we think is that this is something that people are born with. And we'll talk about it a little bit in the coming slides, but there can certainly be different ages at presentations of primary immune deficiencies as well. And this is a picture of zebras, and I know that by now, if you're part of IDF community, you're very familiar with the concept of the zebra, which I think is fantastic. I also want to point out that the zebras in this picture are all different. So while you can certainly recognize the zebra by the black and white stripes, each zebra actually has unique stripes. And so each zebra is a little bit different. And I think that this really fits for patients with primary immune deficiency, because even patients with what we would say is the same primary immune deficiency, every patient is a little bit different. So not everybody's primary immune deficiency responds the same way to all treatments. Not everybody has the same complications or medical problems with their primary immune deficiency. And I think this is an important thing to keep in mind, that every patient is unique. And there are many different signs and symptoms of primary immune deficiency. So I put immunodeficiency here kind of in the center. But around it, these are all of the different types of symptoms and signs that patients can have who have primary immune deficiencies. And so I think that many are familiar with susceptibility to infection. So many of our patients unfortunately suffer from recurrent infections. But there are many other signs. For example, sometimes allergy can be a prominent component of some patients' immunodeficiency. Autoimmunity, so the immune system destroying or attacking parts of the body. This can be things like arthritis. This can be something like inflammatory bowel disease. Bone marrow failure, so a failure of our bone marrow to make immune cells, but sometimes what goes along with this is it also fails to make other cells important for our health, such as red blood cells. Susceptibility to cancer can be associated with many primary immune deficiencies. Again, because one of the main jobs of our immune system is to recognize and destroy cancers. And then finally, chronic inflammation. And sometimes that's inflammation due to infections, but sometimes it's inflammation due to the immune system turning on without a trigger in autoinflammatory disorders. And this can be a sign of a primary immune deficiency. And so a patient could have one of these, a patient could have two of these, a patient could have all six of these. And so really there's a very diverse range of presentations for primary immune deficiencies. And many of you may have experienced this, unfortunately, but this can often lead to challenges in diagnosis. So the patients may be presenting to multiple different specialists. For example, if you have inflammatory bowel disease as part of your autoimmunity with your immune deficiency, maybe you see a gastroenterology doctor. But actually, the bigger problem might actually be the immune system. And so maybe there's also a need to see an immunologist. And I think that this also emphasizes the need for very coordinated care of patients with primary immune deficiency. Often with the immunologist kind of in the center here, working with all of the other specialists who might be treating some of these complications, but to really ensure that we are approaching these diseases and treatment of patients in a way in which we're seeing everything and that we are kind of addressing everything in a coordinated manner. There can also be different ages of onset for all of these. So someone who maybe has infections early on as a manifestation of their immune deficiency, as they get older, it definitely could happen that infections become less prominent and, maybe they have autoimmunity or, maybe there is a risk of cancer. And so just because there is a patient has one symptom with their immune deficiency doesn't mean that that's what it's going to be for the rest of their life. Certainly things can change, things can improve, and new symptoms can occur. So I wanted to speak briefly about testing and diagnosis of primary immune deficiencies. So how do we test for them? So we do a lot of blood tests. Many of you who have been diagnosed with primary immune deficiencies probably know this. But the reason why we do blood tests is that in the process of moving around to all of the different organs and places in our body, the immune cells travel through our blood. And so it's a great way to get a snapshot of what is going on. And in fact, in 1 teaspoon of blood, there should be about 5 million T cells and about 17.5 million neutrophils. So there is a tremendous number of immune cells in our blood at baseline. Certainly having an immune deficiency can alter these numbers and lower them. But it's a great way to get access to these cells, to look and see what's actually there and to see how they can function. Our blood also contains antibodies, and so we can use blood to test antibodies and see how our B cells have actually made responses to immune deficiencies. I also want to briefly mention about genetic testing for immune deficiency. So I think actually right after this talk, you're going to have another talk on genetic testing. But we are more and more using genetic tests to diagnose our patients. And a couple of key points, they are becoming more widely accessible. So it used to be something that was very specialized and only available in certain centers. Really, you can get a genetic testing for immune deficiency just about anywhere now. It has the ability to lead to a precise diagnosis and a change of treatment. So knowing the precise cause of the immune deficiency can actually help quite a bit with how to treat that patient. And we know that about 30 to 40% of patients will have a diagnosis with testing. It is important to remember, however, that there's new discoveries every week. So we're learning more and more about the genetics of immune deficiencies. And so just because you have a so-called negative genetic test or a genetic test that did not reveal an underlying cause, doesn't mean that maybe you shouldn't have new testing or additional testing after that. And then I wanted to finish up to talking about how we can actually treat primary immune deficiencies. And so you're going to be hearing a lot about this when you're kind of in some smaller groups talking about specific diseases, but I wanted to just give you a broad overview. And really, I consider the first step in treatment to be to define and understand what is wrong with the immune system. And so that is figuring out how is the immune deficiency actually altering the immune response and what are the complications that a patient is having with their immune deficiency. I do want to stress that immune deficiencies are lifelong. So these are unfortunately not things that people generally grow out of or that disappear over time. And there really can be a range of treatments, and this is something that is optimized with your physician and based on your diagnosis. So treatments could range from monitoring, which for some primary immune deficiencies, that could be very appropriate. Sometimes it's treating kind of what comes. So treat the infections when they come, treat the autoimmunity, treat the allergies. Many patients with immune deficiency receive antibody replacement therapy, IVIG. We now actually, with our ability to genetically diagnose immune deficiencies, can sometimes use drugs to target the precise pathway that we identify. And finally, there is certainly utility in bone marrow transplantation for primary immune deficiencies, as well as gene therapy, which I think you're going to be hearing about both of these in this meeting. So just to summarize what we've discussed, we have a very large and diverse immune system that works together to protect us from infections and cancer. A coordinated response is essential for our immune response, our immune system. And when you have one part of the immune system that doesn't function properly, you really disrupt that entire coordinated response. And that is the cause of a primary immune deficiency. Testing and treatment for primary immune deficiencies is really targeted to understanding what the immune response looks like in that patient and to treating that individual patient. So I would like to just thank my clinical team at Washington University and St. Louis Children's Hospital and our patients, and I look forward to the Q&A.
Thank you. Now, before we begin the Q&A, please remember that each individual's treatment and condition is unique, and the information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Please always seek the advice of a physician or other qualified health provider with questions concerning a medical condition. And now at this time, please join me in thanking Dr. Megan Cooper from Washington University in St. Louis for that wonderful presentation, and also saying welcome to the Q&A portion of this session. So we have received some great questions, and you are welcome to continue sending in your questions. Just click on the question mark and your questions will be answered. Dr. Cooper will answer as many as possible in the time remaining in this session. So the first question is your IgM, E, G, A part of your T cells or your B cells?
Well, thank you, Kathy, and thanks for having me here. It's a fantastic conference and always enjoy working with the IDS. So that's a really good question. And it's not actually as straightforward as you might think. So when we talk about IgG, IgE, IgA, IgM, these are different forms of antibodies. And antibodies are proteins that our immune system makes that try to target infection. Antibodies basically kind of put a tag on an infection or whatever the body's trying to get rid of and say, hey, the immune system needs to recognize this and take a look at it. And B cells are cells that make those antibodies. So, B cells are obviously very important. And if you lack B cells, you unfortunately don't have the ability to make any of those antibodies. However, you actually need T cell help to make those. And so I talked a little bit about in the talk how we have to really have a coordinated immune response. And so if your B cells can't talk to your T cells because maybe the T cells are gone or the T cells aren't working properly, then the B cells don't really know what to do either, and they can't effectively make those antibodies. So it really kind of takes a good immune response from both the T cells and the B cells and the other parts of the immune system that recognize those infections to make effective antibodies.
Thank you. Next question. Is it unusual to have more than one primary immunodeficiency?
So another good question. I think in general, it would be unusual to have more than one primary immune deficiency. And if somebody was potentially diagnosed with multiple primary immune deficiencies, a question that I might ask is, well, are they actually being diagnosed with multiple different symptoms that are part of the same primary immune deficiency, meaning part of the same underlying genetic cause of whatever their immune deficiency is. And as I discussed, there's a lot of different manifestations of immune deficiency that maybe, for example, if you have allergy symptoms, maybe you're not linking those allergy symptoms to your primary immune deficiency, but they could actually be related. And so this is where it's important to have communication between your doctors. Or say you have thyroid disease and, that you're seeing an endocrinologist for the thyroid disease, and that was never linked back to the immune deficiency. Well, it could actually be part of your immune deficiency. And so I think it would be pretty unusual to have more than one primary immune deficiency, meaning more than one genetic cause of a problem with your immune system. I think it's very likely that you could have multiple different types of symptoms that maybe are not recognized as part of your immune deficiency, but actually are. And so working with your immunologist and your other doctors is important for that.
And along that same line, I have CVID. I also have low IgA or no IgA, and I do not make antibodies. So I have been saying my diagnosis is CVID, selective IgA deficiency, and hypogammaglobulinemia because I got all those things. So what do I tell people? Do I have those three PIs, or do I have just one?
Well, that is another great question. So when I put up that picture of those zebras, this is a great example of how everybody, with the primary immune deficiency, yes, it's a zebra, but actually, even when you look at zebras, their stripes are all different and they're all different. So based on kind of what you told me in the question, I would say that your underlying primary diagnosis is CVID, but everybody with CVID can be a little bit different. Some people with CVID have a lot of lung disease with their CVID. Some people with CVID might have gastrointestinal problems with that. And so I would say that in that case, you have CVID, and for your particular CVID, it affects primarily your ability to produce antibodies. Having hypogammaglobulinemia is a description of low antibodies, and having low IgA is another description of having low antibodies. And so it's important to kind of remember those other diagnoses because that really describes your particular CVID and kind of distinguishes you from maybe other patients who have that CVID diagnosis.
I have hyper IgM syndrome. Is this a B cell defect or a T cell defect?
So that is another fantastic question, and it really depends on what the underlying genetic diagnosis you have for your hyper IgM syndrome is. So there are some forms of hyper IgM syndrome where it's purely a B cell problem. And in hyper IgM syndrome, what happens is the B cells don't really understand how to make different types of antibodies. And what tends to happen is there's a buildup of IgM antibody rather than maybe the more productive IgG that we need to fight infections. And so hyper IgM could result from an intrinsic problem of your B cells to not be able to switch between those different types of antibodies. Or it could actually result from a problem of your T cells telling your B cells, hey, it's time to switch, and that switching occurs as the B cells start to get better and smarter at recognizing a particular infection. And so it could either be a T cell problem or a B cell problem, and that would be a question for your physician, and would really probably be based on what the genetic diagnosis you have is.
Is there a link between dysautonomia, POTS, and primary immunodeficiency?
POTS and dysautonomia are certainly linked. In terms of thinking about primary immune deficiencies, there has been some very interesting work out of the NIH that kind of linked a genetic cause in tryptase to kind of linking together dysautonomia and POTS. The link to the immune system there, I think, is less clear, and it's not clear that there's a genetic link to other primary immune deficiencies or more typical defects of the immune system where the immune system would leave you susceptible to infection or to autoimmunity. But certainly, I think that given the number of individuals that suffer from this, it's interesting to think about that link and potentially areas of future research.
Can specific antibody deficiency be treated with cord blood?
So specific antibody deficiency typically means that you maybe have normal levels of antibodies, so that IgG level, if you just look at all of the IgG in your blood, is normal. However, your B cells and your immune system doesn't know how to make productive antibodies, meaning that while you have a lot of just antibody there, it's not very good at, when it sees an infection, making the right kind of antibody that you need for that infection. So specific antibody deficiency is generally treated with immunoglobulin replacement therapy. There's really probably very few indications in which cord blood would be used for specific antibody deficiency. Cord blood we do use for immune deficiencies as a donor source for bone marrow transplantation. So that cord blood contains a lot of what we call hematopoietic precursor cells, or cells of the bone marrow that can help to make your immune system. And so if we need to replace the immune system of a patient, cord blood might be an option. In most cases, specific antibody deficiency is well treated with immunoglobulin replacement, but there could be some circumstances in which a bone marrow transplant, potentially using cord blood as a source, might be appropriate.
If I haven't had genetic testing, should I do that?
Yes, I would say, and I think I talked about this in the talk, that every patient diagnosed with a primary immune deficiency should have genetic testing. We know that certain populations of individuals are more likely to have a genetic diagnosis. So patients who are younger, patients who have more severe disease are more likely to have a genetic diagnosis. But even patients who are older can certainly have a genetic diagnosis, even if they didn't have symptoms for the first several decades of their life. And we're beginning to understand that as we're testing more patients. And so while kind of the positivity rate, or our ability to define the underlying genetics of an immune deficiency kind of varies based on the individual patient, I do firmly believe, and I think that many of us in the field treating immune deficiency patients, that patients deserve that option for genetic testing.
What role does the AIR gene play on autoimmunity?
Sure. So that is another great question. The AIR gene is actually very important for our immune system. So I talked in the talk about the different places where immune cells kind of go to grow up and to become educated. And one of those really important places is the thymus. And the thymus is an organ that sits on top of our heart. And it is a place where T cells go to grow up. And in the thymus, T cells really learn the difference between good and bad. And so T cells should really learn what our own cells, our own body looks like, and they should learn that they should ignore that. AIR is actually very active in the thymus, and AIR plays a critical role for teaching T cells to recognize our own proteins, our own body. And so if a T cell doesn't encounter our own proteins and doesn't learn that in the thymus because AIR is absent, then that can lead to autoimmunity, because T cells may be able to leave the thymus and not know the difference between an invader and ourselves. And so patients with AIR have a lot of different autoimmune problems. They can often have problems with their parathyroid gland, their adrenal gland. They can have liver problems and other autoimmunity. So it is a significant condition. And really, by understanding what's going on in these patients, we've learned a lot about how the immune system is educated.
I was diagnosed with CVID February of 2020 and began receiving IVIG that April. I am 68 years old. I suspect I had problems for 5 years and went to many specialists. My question is CVID the same as primary immune deficiency? Is mine still genetic?
So CVID is one type of primary immune deficiency. So definitely yes. We currently categorize over 450 different types of primary immune deficiency. So I can see it being very confusing. So you can almost think of it like an infection. So you can have an infection caused by Staph aureus. You can have an infection caused by a fungus. Those are all infections, but just caused by different things. And so CVID is one form of a primary immune deficiency. And it is possible that there's a genetic cause that could be identified. I will say that in many older patients with CVID, we're unable to identify one single genetic cause. And in that case, we think that there may be an influence of not just genetics, but also environment and other factors there. So I think that it is possible there could be a genetic cause, but probably less likely, but still based on kind of the accessibility and the relatively low cost of genetic testing and the information that you can gain by having a genetic diagnosis, I still would advocate for it.
What percentage of anticonvulsant-induced hypogammaglobulinemia also have CVID?
So I'm not sure that I completely understand this question, but it sounds like maybe there was a medication side effect. And so I'm not sure I could give you a exact percentage on that. Certainly when you're being diagnosed with an immune system problem, it's important to consider different factors that might be causing that immune system problem. For example, is it a genetic factor, or was there an infection, or in this case, I think the individual's asking about potentially a drug. And that's something you can work on with your physician to see, is there maybe another cause to what's going on there? Yes.
I was referred to a hematologist versus an immunologist. My diagnosis ended up CVID. Does it matter what type of doctor I see?
Yes and no. So you should see a doctor who's familiar with diagnosis of immune deficiencies, but I will say that those of us that treat immune deficiencies come from all different types of backgrounds. So my background actually is as a rheumatologist. And as a rheumatologist, I have developed a special interest in the immune system and really specialize in immune deficiencies. And many hematologists specialize in immune deficiencies. Many infectious disease doctors might specialize in immune deficiencies. So this really also reflects the very kind of broad symptoms that our patients have and our need for multidisciplinary care. So I think that seeing a hematologist is fantastic. And if that person has the expertise and the background in treating immune deficiency patients, that sounds like a great fit.
How long does it take to know whether or not our IgG levels increase after we have been taking an immune suppressing drug?
So I'm thinking that this question is maybe suggesting that someone maybe had low immunoglobulin related to an immunosuppressant they had to take, maybe for the autoimmune disease or another cause. In general, if you're still taking the immune suppressant, it might be that your IgG will remain low. It probably depends on the drug that you're taking, the dosage that you're taking. If you were to stop the medication, and you're kind of asking about looking for, okay, when will my immune system be able to recover and that IgG will go up? I think that, within 3 to 4 months in general of stopping the medication, you should see that IgG start to go up. But really, that probably depends on a lot of factors like the underlying reason you were taking the medication and any other medications you might be taking.
I was originally diagnosed with CVID, but they said I didn't really qualify because my IgG, although it was low, was not low enough for CVID. So then they said I have specific antibody deficiency and hypogammaglobulinema and anemia. Is this just a problem with how they diagnosed me, or what do I really have?
Well, I'm not sure I'm going to be able to tell you what you really have. And I would obviously refer you to your doctors for that. But I think, in some cases, what might have happened here is, unfortunately, different insurance companies will also have different criteria for how they might diagnose CVID in terms of having an IgG level more than 2 standard deviations below the lower limits of normal is sometimes a frequent criteria, versus your doctor, who maybe has a lot more experience, can look at your immunoglobulin levels in combination with your vaccine titers, meaning your specific antibodies that you make to vaccinations. And I would trust your doctor on the diagnosis. I will say that sometimes, in that situation, if you didn't meet diagnostic criteria for CVID, potentially based on some other criteria that maybe your doctor wasn't using, that specific antibody deficiency can be a very similar diagnosis, and the treatments are similar. So I think that's probably going to be a question for your physician.
Are there any alternatives to vaccine challenges for those who have never been vaccinated but think they have a primary immunodeficiency and want to be tested?
Vaccine testing responses to vaccinations is really one of the best ways that we have to look at that. And I think this would probably be something to work with your immunologist on, and maybe talk about what the concerns with the vaccination were. Certainly, without testing vaccine responses, we're able to look at numbers of immune cells that are present, and in general, the amount of antibody in the blood. But knowing if the immune system can actually make a specific antibody, meaning make a productive antibody response to something in particular, it's immensely helpful to know when a patient received a particular vaccine and how they responded to that vaccination. And it can also obviously help to prevent significant illness in patients who have a compromised immune system, who might be at increased risk for illness.
I'm 60 years old and have been diagnosed with CVID since age 52, currently receiving weekly infusions. My question is that I experience widespread pain, mostly in my bones. Do you have any feedback regarding the bone pain? And could the cause for that be something that could be tested for by common blood tests?
Bone pain can be very complicated, could be due to a number of different things. And I think that this is probably going to be a question best addressed by your physician. Certainly, patients with CVID are at increased risk for things like having arthritis, which can cause pain in joints, but also more widespread pain. I might ask your physician about that. And I think nothing in that situation can replace a really good physical exam in kind of trying to locate where the pain actually is. And depending on that physical exam, there certainly, I think, would be some blood tests that could help out your physician in your particular case.
Thank you. We have 1 minute left, and we have one question that we can answer. If your question wasn't answered, please talk to your doctor or send your question over to Ask IDF. And we do have your name. We will try to follow up with you if possible. But last question, is genetic testing covered by insurance?
Oh, that is a really good question. So it really depends on a lot of things. It depends on the insurance plan that you have, and it depends on the particular diagnosis that you have. So I will say I treat children, and in most cases, the genetic testing will be covered, but it often requires that I write a letter or speak to someone at the insurance company to explain to them and to really advocate as to why we need the genetic testing. And this is a great issue to think about at this IDF conference, and how patients can advocate for themselves and advocate for access to things like genetic testing that can really help aid diagnosis and treatment of these therapies. And I know that the IDF is certainly a supporter of enabling patients access to genetic testing. In some cases, if insurance does not cover genetic testing, there are certain options for relatively low cost or sometimes even no cost genetic testing, depending on the diagnosis, and that might be something to talk to your physician about as well.
Thank you. Thank you so much, Dr. Cooper. As always, you are wonderful. It has been an absolute honor to have you joining us today. And to everyone else in this meeting, enjoy the rest of the conference. Take care.
Thank you.